Hello everyone, we are now going to go over the peripheral blood flow cytometry plots from a 4-day-old neonate with Down syndrome and few circulating blasts. So there are a couple of things in this history that we need to pay attention to. One is this is the first week of life of that neonate. He's only 4 days old and the patient has Down syndrome. So now let's start with CD45 versus side scatter. And we have 45% cells in the lymphocyte gate, 4% in the monocyte gate, 40% in the granulocyte gate, and the blast gate as defined by dim CD45 and low side scatter shows 8% of the cells. Now, when we track these cells, they're negative for CD34. There may be a spray of cells with CD34, but they're largely negative. They express CD33, partial CD117, they're negative for HLA-DR, and again, they're positive for CD33, they're negative for HLA-DR, and they do not express CD15, and they have a partial dim CD13. They're negative for CD11B, they're negative for the monocytic markers 14 and 64, again, negative for 11B, they're positive for CD56, and when we go to the next tube, so far we see that they express myeloid markers, CD33, 117, partial CD13, and they're negative for HLA-DR. And they express CD56, apparent marker CD56. That's what we saw now. In the T cell tube, we see that they're negative for CD3. They may have a partial CD7. Again, they're negative for CD2, negative for CD4 and 8, and they're negative for the B cell markers 19, 20, and 10. And now in our additional tube, we have to add this because if you remember, the patient has Down syndrome and it is a neonate. So Down syndrome patients are prone to develop megakaryocytic leukemias. So we always add this tube that contains erythroid and megakaryocytic markers to phenotype our blasts. And so these are positive for CD36. CD36 is non-specific. It can be positive in megakaryocytic blasts, erythroblasts, and monoblasts. CD36 is positive here, but CD61, that is specific for megakaryocytic lineage, and CD61 is positive. 41A is positive. Again, 36 and 41A shows that it is positive, and 61 is positive. And glycophorin, which is the specific erythroid marker, that is negative. So the blasts have a megakaryocytic lineage, and they express some of the myeloid markers like 33, 117, and some 13, and apparent CD56. These are negative for CD34. So when you have something like this, you have to remember the two conditions that are associated with Down syndrome. In general, these are called myeloid proliferations associated with Down syndrome. You have a category in the WHO, and it encompasses two entities. One is transient abnormal myelopoiesis associated with Down syndrome. It's called TAM. The second one is myeloid leukemia associated with Down syndrome. So TAMs, that is transient abnormal myelopoiesis, it means like you have an increase in the blast population in the peripheral blood, and it's kind of transient. It will disappear over time, usually within several weeks or a couple of months, and these usually manifest in the neonates in their first week of life, typically within 3 to 7 days. You'll see, and these blasts are megakaryocytic lineage. The reason that these blasts are megakaryocytic lineage is because these patients also have a mutation in GATA1, and that results in a truncated protein that ends up increasing the proliferation of megakaryocytic cells. So that's why these blasts usually are megakaryocytic lineage. And just by flow, or even in the early stages, there is no way you can differentiate between whether this is transient or TAM, or it is a myeloid leukemia associated with Down syndrome. When you report, you can only give the percentage of the blasts and their phenotype. So in this one, it is 8% blasts with megakaryocytic differentiation. That's all you can say, and give a phenotype. Clinically, they have to follow the patient to see if it is disappearing, which means it is TAM, or if it is persistent, which means it is myeloid leukemia. So even if it is TAM, there is a risk of these patients developing frank leukemia in the next few years of their life, usually when they're in 2 to 3 years. So they usually follow these patients closely. So normally they would express the myeloid markers CD34 and the myeloid markers 117, 13, 33, and they do not express the monocytic markers, and they express megakaryocytic markers 41, 42, 36, and CD61. They do not express glycophorin. So that's how the phenotype is. Some say that 50% of myeloid leukemias are negative for CD34, unlike TAMs. TAMs, they say, is usually positive for CD34. And also CD56 is usually negative in myeloid leukemias. In TAM, it is usually positive. But just by phenotype, you cannot really precisely say if it is TAM or myeloid leukemia. That has to be a clinical decision. For us, we can say the percentage of the blasts and the phenotype, and then say that this is a myeloid proliferation associated with Down syndrome. Thank you.